My name is Mark Rosenzweig. I'm a patient with ALK-positive lung cancer since 2013, and I'm so fortunate to be around in 2024. And with research and all the breakthroughs that we've had, I've been very, very fortunate. And our YouTube channel is you go to ALK lung cancer, pop in ALK-positive, and you'll see us. All of our ALK talks are recorded, and we do have a special guest. And I just want to say that I do watch Dr. Liu's podcast, and I do follow you on X or Twitter, and you're like a connector of many thoracic oncologists, and you do a wonderful job. And so I'll mention that. And I'm going to watch some polls, as I always do, and so give Dr. Liu a opportunity to see who's in the audience. So give me a minute here. So what is the type of treatment that you are receiving? Hey, Summer, give us the update, what the answers are.
As what is the type of treatment you are receiving? 5% are on chemo and a TKI. 56% of you are on alectinib. 7% brigatinib, that would be myself included, but I did not take the survey. Lorlatinib, we have 24%, straight chemo 2%, and 4% on a clinical trial.
When were you diagnosed?
And when were you diagnosed? Under a year, 20%. 1 to 2 years is the winner tonight at 23%. 2 to 3 years, 16%. 3 to 4 years, 20%. 6 to 7 years, 15%, and 8 years at 7%.
I just want to remind everyone that you can go to your closed caption. If you want to, on your square, just hit the 3 dots and you'll see it. And I will pass it off to Summer.
Thank you all so much for joining us. It's been a minute, right? We haven't seen you since the early June when Yvonne and I were still at ASCO, along with Ken Culver and Mark Muscovich, and then Kirk and Nancy had just arrived home, and we had Mark and Katie and Dana at our home base also helping to pull all of our exciting information for our talk together. So thanks for joining us again this summer evening. ASCO, in case you need a refresh, is the American Society of Clinical Oncology. They hold an annual meeting where there are about 40,000 global oncology experts all smashed together. It was quite astounding. And they range from oncology experts in every discipline, including patient advocates and pharma, biotech. So it was very exciting. While you're there, a lot of new information is unveiled and released, new treatments, therapies, all sorts of things. So it's a lot to unpack. And while we were at ASCO, we were also monitoring what was happening on our ALK community and the Facebook page, and questions were popping up. What does this mean for us? What does this data mean? So we thought we would bring in the fabulous Dr. Stephan Liu. He is a professor of medicine at Georgetown University, director of thoracic oncology, and head of developmental therapeutics at Georgetown Lombardi Comprehensive Cancer Center. I've always wanted to meet him anyway because I've heard from patients and just read fabulous remarks from him. He is endearing and is very much a patient advocate that focuses on an open communication, patient-centered. And so, you know, that is what we all, the relationship we all strive to have with our oncologists. So we're so happy to have him here tonight. Also joining us is Yvonne Diaz and Dana Quirito. So Yvonne will be helping with moderating, and Dana will be keeping you all in check, muting and letting you in. So thank you all, and Ken Culver as well, I believe I mentioned earlier. And also, Dr. Liu, I should not forget that you are also the co-host for the official ALK podcast, Lung Cancer Considered. So everybody jot that down, add that to your must listen to. That was what Mark talked about earlier, full of great information and great patients, such as our very own Yvonne Diaz. So thank you so much, Dr. Liu. Take it away.
No, thank you for the invitation. I was wondering when I'd get the chance to come on. So it truly is an honor. And Yvonne and I have met a few years ago now, I think. And so I'm glad to be here. And I thought what I do while I had you in the room was maybe talk a little bit about what ALK is and sort of where we've come. I put together a few slides. It's not meant to be a lecture, but I thought it might help illustrate some of the points we wanted to make today. ALK in 2024, raising the bar for targeted therapy. Again, my name is Stephan Liu at Georgetown University in Washington, D.C. I've been here about 11 years now. I do want to note that I do have some disclosures that I do want to be transparent about. So when we think of ALK positive lung cancer, ALK fusions are present in about 3.5% of adenocarcinoma. These numbers will vary a little bit depending on region. These are the numbers, we haven't published these yet, but these are the most recent ones that we came up with in the US as of 2024. And I think arguably the greatest successes in targeted therapy really have come with ALK. Let's take this opportunity to talk about where we are now, how we got here, and maybe where we go next. If we go back to ALK, the history is not that long. ALK fusions were known for quite some time to be present in lymphoma, which is a type of blood cancer. ALK, as we know, stands for anaplastic lymphoma kinase. And at the time, we knew they were in these rare types of lymphoma. We weren't too focused on developing drugs there because that group of lymphoma actually responds pretty well to chemotherapy. So we knew these existed, but they seem to be in a different type of cancer. They were first identified in lung cancer, non-small cell lung cancer, 2007. It's not that long ago. Dr. Soda first described these as in a case of non-small cell lung cancer. And when these were described, when they were first discovered, people were very excited. The reason they got excited is because we had a drug in the clinic that was an ALK inhibitor, and that's our old friend crizotinib. I had a chance to sit down with some of the people involved in that trial. That trial was called Profile 1001. We did a podcast episode on that with myself and Dr. Narjus Flores from Mass General. We sat down with Ben Solomon, with Ignatius Wu, and with Alice Shaw, and we talked about this study, such a fascinating example of drug development. This was a first-in-human study for this drug called crizotinib. We may know it as Xalkori. Now, at the time, when that study first started, this was a drug that was synthesized by chemists, some very talented medicinal chemists that have played a very important role in drug development for ALK in particular. But they developed this pill that could block MET, M-E-T, and they were focused primarily on stomach cancers. Stomach cancers often had high levels of MET activity, and crizotinib was focused to block MET. That study started in 2006. Dr. Soda discovered ALK as a target in 2007, and people scrambled at Pfizer because they said, well, this drug could block ALK. I wonder if this could be a lung cancer drug. And so within a year, in 2008, they added a cohort. They modified this existing study to allow patients with ALK-positive lung cancer. This was remarkably fast, especially because this was a time when we weren't doing next-generation sequencing. The testing was something called FISH, fluorescent in situ hybridization. And for those who are familiar with the field, FISH is a very labor-intensive way to find an alteration. It involves someone looking under a microscope and counting 100 different cells, and they had to develop this specific probe to find the ALK rearrangement. The person that developed that test is called John Iafrate, and all of these tests were done in his lab, in a single laboratory. In 2008, they launched that study, and people were just sending tissue to Mass General for Dr. Iafrate and his lab to tell them if they had the FISH alteration. He did countless assays, really slaved day and night, doesn't get the credit that he deserves, found all these samples, and Dr. Shaw presented these data in the World Lung Meeting 2010. The very first patient that went on this study had a dramatic response, really validating ALK as a target and showing that crizotinib really could work wonders. When these data were presented in 2010, only after 2 years of the study being open, the response rate was 61%. The disease control rate, 83%. Responses were quick. They occurred generally at 2 months, the first scan. They were durable, lasting almost a year. The progression-free survival there about 10 months. And based on this, the FDA granted accelerated approval the next year, 2011. So from finding ALK in lung cancer, 2007, modifying a study in 2008, 3 years later, having an approved drug, really remarkable speed. And that didn't happen by accident. The hard work of everyone involved really changed the field. And this was a big deal. It's really changed the paradigm in so many different ways, more than just one drug being approved. First, this time from discovery to approved target, but also the fact that targeted therapy wasn't just this one-off. See, we knew about EGFR mutations at the time, and that was it for targeted therapy. And so a lot of oncologists, a lot of community oncologists in particular, thought, well, this is sort of an exception. This is a rare type of thing. When we see the second and we see how well this works, we know this is actually here to stay. We need to really change the way we're thinking about lung cancer. There's more than one target. Really, everyone needs to be tested for these. In addition, accrual for this trial was remarkable. This was only open at a handful of sites: University of Colorado, Mass General, UC Irvine, Peter Mac in Australia, a handful of sites around the world. And in 2008, social media was just in its early stages. This was a lot of word of mouth. And we didn't have forums like this that could spread the word so quickly. It really was remarkable that this study was done. Other paradigms that were broken, this was approved based on a single arm phase 1 study, a pretty small trial, but the FDA saw this was real. We needed to get this out there, and it really changed their way of thinking. It was agnostic to line of approval. It didn't matter if it was first line or second line. Ultimately, again, just like EGFR, targeted therapy replaced chemotherapy. And another sort of interesting paradigm here is that the drug development, and I think thanks to people like Ken, really met all of the unmet needs, really was designed, focused on what the patients needed to sort of take that next step. And I think that ALK has done that better than any target, primarily with CNS. We know that ALK lung cancer has a strong attraction to the brain, something called tropism to the brain. And in some studies, we'll see 24% present at diagnosis, almost half at 2 years, over half at 3 years. If we look at older studies of these crizotinib, we see that if you started off with brain metastases, started with crizotinib, 70% of the time, the brain was going to be the site of progression. And if there was never any history of brain metastases, still 1 in 5 developed brain metastases at a median of about 2 years. And so knowing this, observing this, drug developers said, look, for any drug to be worthwhile, it needs to be better in the brain. And when we're designing drugs that can work after crizotinib, they're only worth taking to that next step if they're going to be very potent in the brain. And the next drugs that made it through that line all were. Ceritinib, approved by the FDA in 2014, ALKtALK in 2015, brigatinib in 2017, and lorlatinib in 2018, all with very high CNS response rates shown there on the right. All of these would then go on to be approved in the frontline setting as well. And this represents really the next generation of drugs. We focus on those bottom three: ALKtALK, brigatinib, and lorlatinib, as sort of the preferred, most commonly prescribed frontline agents, all very active in the brain, very potent. They were all compared to crizotinib, and hands down were better than crizotinib and really represent our standard of care. Which brings us to sort of an important point. Which one should we use today if we're diagnosed with an ALK-positive lung cancer? What is the preferred agent, and what are the differences between these three agents? They were approved based on randomized phase 3 trials. And so in a randomized phase 3 trial, all the patients enroll, half of them, or sometimes more than half, will receive this new medicine, and then the other half would receive the old standard, which was crizotinib at the time. The ALKs trial was a study that led to the approval of alectinib. And here, the median progression-free survival, so the time from starting treatment until the first sign of cancer growth, was about 3 years, 34.8 months with alectinib. The hazard ratio of 0.43 means that if you were taking alectinib compared to someone taking crizotinib, you had a 57% reduction of the risk of progression or death. And so about 3 years on average. Not everyone gets to 3 years, and some get well beyond 3 years. Alicia was a similar study done in China. And so this was mostly done in East Asia, not just China, but mostly in East Asia. And here we see the number a little bit higher, 41.6. Even though the study designs were the same, the numbers will be a little bit different sometimes, which shows that it's difficult sometimes to compare across different studies. One thing that we don't talk about a lot is that when someone enrolls on a trial, it's sometimes a very different patient population. Trials are very selective, they're very picky. And so they have a lot of very strict criteria. For someone to enroll in trial, everything has to be kind of perfect. And over the years, we've seen that the patient population that is enrolled on a randomized registrational phase 3 trial doesn't necessarily reflect the population that I would see in my clinic. The patients in my clinic might not qualify for the trial due to some other comorbidities, due to kidney function, heart function, overall strength, things of that nature. In addition, unfortunately, and something again we don't talk about a lot, the socioeconomic status, the race and ethnicity demographics also do not reflect the population. And there are a lot of social determinants of health that really dictate whether someone is able to enroll in a trial or not. So the trial population sometimes can be a little artificial, and the numbers aren't always the same. And so when we look at alectinib in the real world, the numbers aren't quite as good as this. If we look at an average or median number of 41.6 with alectinib in Alicia, in the real world, the numbers are a little bit lower. The Explore ALK study is a French study looking at 120 patients. The response rates are very high. Almost everyone responds. They can be durable. It works well in the brain, but in the real world, that progression-free survival is not 42. It's a little closer to 28. In the US, the number is probably closer to 24. The numbers deflate a little bit in the real world. Brigatinib is another agent approved in the frontline setting that was approved in the ALTA-1L study. And there, the median progression-free survival, 30.8 months. As we showed with the difference between alectinib in the ALK study and the Alicia trial, comparing across studies is a dangerous game. And so we can't really look at this 30.8 and compare it to that 41. They're different studies, they're different criteria, different populations separated in time and space. And so looking at this comparison to crizotinib, we see the relative benefit of 0.43 actually identical to what we saw with alectinib. This is also a very potent and active drug. But the more recent data presented at ASCO this year from our friend Dr. Ben Solomon looked at lorlatinib. This is the most recent cut from the lorlatinib data in the CROWN trial. And this was about 300 patients that were randomized 1-to-1 to receive either lorlatinib as their very first treatment or crizotinib. And at 5 years, we still have not yet reached the median, meaning the median is going to be more than 5 years, more than 60 months. My guess would be probably closer to 6 years. The hazard ratio, which shows that relative benefit and lower is better, was 0.43 and 0.43 for alectinib and brigatinib, 0.19, clearly lower with lorlatinib. And you can see that red line there represents patients on crizotinib, and progression happens very quickly there within a year, whereas with lorlatinib, we see much more durable periods of control. There's a lot of important data that we talked about with lorlatinib. It was clearly better in anyone with a history of brain metastases. And that PFS hazard ratio of 0.08 is profoundly better. Again, at 5 years, 53% of people with brain metastases still have not yet had progression. Without brain metastases, even better at 63%. And there are some subgroups of ALK that we know do not do as well with targeted therapy. There's a lot of heterogeneity within ALK. Not all ALK fusions are the same. There are different fusion partners. The most common by far is a gene called EML4. But within EML4 and ALK, when these genes come together, they can come together in different points, different places. And those fusion variants really inform the biology there. We can see variant 3 is a particular variant that does quite poorly with alectinib, with brigatinib, but they did quite well with lorlatinib. Here, variant 1 and variant 3 both doing very similar with lorlatinib, performing well in groups that are otherwise difficult to treat. If we look at these across studies, again, difficult to do this validly, but the hazard ratio for lorlatinib clearly lower. This is the most potent. Here, the median progression-free survival is the longest, without question, with CROWN. Now, Ken will notice that those confidence intervals do overlap a little, and so statistically, the differences might not be as vast, and these are not compared head-to-head. Those kinds of studies aren't really done, so we won't see these directly head-to-head. But I think the longest PFS is lorlatinib, there's no question. So what's the flip side of that coin? Well, the flip side of that coin is toxicity, and the toxicity with all these agents is different. Every medicine we have has its side effects, and for us to choose the right medicine, it's always a balance of how well it works and what effect it has on our quality of life and our day-to-day living. Alectinib, we look at the rate of dose reduction. How often do people need to reduce the doses? About 20%. How often do people need to stop treatment? In the studies, about 15%. And the most common reasons there, LFT or liver test enzymes, sometimes myalgias. With brigatinib, the rate of dose reduction you see there is quite high. In the real world, it's not that high. A lot of these were due to elevation in the lab called CPK. This doesn't really have a lot of clinical significance. How often is CPK elevated in my practice? I don't know because I don't check. And if you don't check, you don't have to reduce the dose. This generally has no clinical impact. There are early onset pulmonary events, which are not really pneumonitis, something a little bit different, but those are transient. They go away with time. This is a medicine that overall is very well tolerated. Lorlatinib, the rate of dose reduction there, 23%. I think in the real world, the dose reduction rate is pretty similar between all these drugs. The rate of discontinuation also in the same ballpark, 11%. But the types of side effects you see are a little different. Well, let's talk about those. From an efficacy standpoint, I think there's no question lorlatinib is the longest progression-free survival. But in terms of toxicity, these drugs are different. For lorlatinib, 62% did require a dose hold, and 23% had grade 3 weight gain. What that means is 23% of patients noticed their weight increased at least 20% from baseline. It's a lot of weight gain, and that's something that can occur over time, especially as you're taking this drug for years. What I think is most concerning and maybe just most important in terms of awareness are the CNS toxicities, and they come in all different types. 42% of patients had CNS adverse events, and 14% of those were severe. CNS events can be something like a headache. It can be something like foggy memory, but it can be something a little more serious and sometimes a little more insidious. Ones that I'm concerned about are mood. Depression is, I think, underreported, and it can be severe enough to even induce suicidal thoughts. And I've seen that firsthand in patients. And if we don't know that that's something that can happen with this, it can go sort of unseen. What's most concerning to me is something that probably doesn't even show up on these toxicities. This drug works extremely well in the brain. And that's important. And it's a very good drug. But the effect that it has on the brain is something we need to be very aware of. And there are cases that I have seen where it can change our personality. And here we get into almost like an existential type of side effect, where if we give you a medicine that's going to work really well against the cancer, but it's going to fundamentally change who you are, change your likes and dislikes, change your personality, is that something that we want to take? And from my standpoint, is that something that I will even recognize? If I only have 10 or 15 minutes in a room with a patient, can I tell if they've changed their values, if that person has changed in some way? And so when we start a medicine like this, it's really important that I fully disclose the types of things that can happen, because if we see those types of side effects, and this is the important part, if we see these side effects, they can respond to dose reduction. It just means the dose is too high. And if we lower the dose, those can be undone. But if we are not aware of it, and if we're not preparing patients for it, and these side effects continue, it can damage relationships. We've seen divorces. We've seen people who get alienated from their children because it sort of changes how they interact with different people. And so if we reduce the doses, those side effects go away. It's just really important that we are aware of those side effects. So if it does occur, we can see it. So when I'm starting someone with lorlatinib, which I do, I make sure the patient understands these side effects, but I also make sure the patient's family, their spouse, their caregiver, and if at all possible, I want those patients in the room with me to say, are things changing? Is someone getting a little more moody? Is someone getting a little more angry at times? And, sometimes those are things that just occur with the diagnosis of lung cancer, but they can be related to the treatment. And so it can damage relationships, friendships, and these things are important. And that can improve with dose reduction. And a very important piece of data that came out of ASCO from Crown was that if we reduce the dose in the first 4 months, it did not decrease the efficacy. Again, the goal here is not to be on the highest dose, it's to be on the right dose. And for a lot of people, 100 milligrams is not the right dose. And so it really is up to the doctor to understand we can reduce the dose, to reassure the patient that a lower dose may be right for you. And if it brings down those side effects, it doesn't necessarily mean that drug is going to stop working. Here, if you like the progression-free survival, the higher number, the better number is actually people who got a dose reduction. Now, statistically, they're going to be the same. But reducing the dose does not necessarily compromise how well the drug works. We want to make sure someone is on the right dose. So these side effects are not things necessarily to be afraid of, and it shouldn't discourage someone from using these drugs, but it's important that we're aware of them and that we recognize them early. But I fully admit that can be very challenging. There are still a lot of unanswered questions. Number one is how well is the drug going to work in the real world? If we look at the median progression-free survival in Crown, it's going to be out closer to 6 years. What is it going to be like in reality? When we look at these real world data, it's going to be lower. How much lower? In addition, these dose reduction discontinuation rates are those what we're going to see in real practice, or is it going to be a lot higher? And I guess the big question is, can we use these drugs in sequence? Can we sequence them, and will that allow us to get longer use going one after another rather than starting with lorlatinib? And that's a tough question to answer. Now, the CROWN study, unfortunately, did not allow crossover. And so people that received crizotinib, they were not given lorlatinib when their cancer progressed. And there are complicated reasons for that. And I think Ken might actually be able to speak to that even more than anybody. But CROWN did not allow crossover, so we won't have those data directly from CROWN. Now, sequencing is a little tricky here because we do have some data from lorlatinib when we use it as drug number 2 or drug number 3. There was a study, a phase 2 study that looked at crizotinib in patients who had a prior drug, mostly alectinib and ceritinib. This was sort of in the early days. A few patients had brigatinib. Now there, the chance of response was only 30%, and the progression-free survival only 5.5 months. So that short progression-free survival of lorlatinib when we use it as drug number 2 kind of argues against sequencing it. And these are not drawn to scale, but if you sort of get a general sense, I don't think we need to be a PhD doctorate in math to understand that 35 plus 6 is nowhere near 72. But that's 6 months. Is that real? Is that really how well lorlatinib works in that setting? There was a little bit of data that came out of Prague this year at the ELCC meeting that did not get a lot of attention, but I thought it was really important. This looked at the ALTA-1L study. Now, if you remember, that was a study where patients received frontline brigatinib as drug number 1. And all they did in this update was they said, how did people do with their second drug after starting with brigatinib? And a lot of those patients did get lorlatinib. And so the question is, if we start with brigatinib and then go to lorlatinib, is lorlatinib really only working for about 5.5 months? And what we saw was absolutely not, that lorlatinib actually looked really good after brigatinib. If we look at the averages here on right, the real world progression-free survival for people that had lorlatinib as second line was 25 months. So if they started with brigatinib and then went to lorlatinib, they stayed on that lorlatinib for 2 years. And if we look at the PFS2, which is the time from starting brigatinib until the second drug stopped working, that was 75 months. Now that looks a lot closer to what we're seeing in CROWN. These are different populations. These are small numbers, but I think this is really an unanswered question. And my expectation is lorlatinib will work a little better after brigatinib than we saw in some of those early studies. But a lot of these questions are unclear. These real world frontline and second line lorlatinib questions will be answered. How can we further personalize these data? Can we predict toxicity? And what about resistance? Now, what we did see is that when we started with lorlatinib, those patients that progressed, when we looked at resistance, we did not see resistance within the ALK gene, which means that newer ALK inhibitors like SY3505, like NVL655, probably are not going to work after lorlatinib specifically, but they are going to work, I think, fairly well against a drug like alectinib or brigatinib. It seems like most of the resistance to lorlatinib is outside of ALK, pulling in other genes, which makes it a little bit different. Off-target resistance is a real challenge. And we do have newer drugs. We mentioned NVL655 in the ALKOVE-1 study. This study being led by Jess Lin at Mass General. I'm sure that this is very effective for a lot of resistance mutations. So should we sequence? Should we start with lorlatinib? I think that there are a lot of different opinions on this, and we don't really know what the best option is. Lorlatinib is clearly a drug that works for a very long time, and I do think it's appropriate for a lot of patients. At the same time, for the past 7 years, we've been using alectinib and have had very good responses. And I have so many patients that are still on first-line alectinib that started that first year it was approved in 2017. And when I think of the quality of life those patients have had with alectinib, I think it's something that I'm not quite ready to let go of. So it's a discussion. I think there are some cases where lorlatinib is clearly a better agent, like in variant 3 with a P53 co-mutation. There are some cases where I think lorlatinib is head and shoulders above the rest. In the other cases, I think that we need to learn a little bit more to really optimize and further personalize the treatment. And this is also going to be true in the adjuvant setting. The ALINA study looked at alectinib for patients who had surgery. And our hope is that we detect more of these cancers early. And if we resect a cancer, we know that those patients can be cured. But we also know that we don't cure most patients after surgery. Giving alectinib after surgery did seem to keep that cancer away. And if we look here at the disease-free survival, the blue line is alectinib. And we are, again, are not at the medians yet, and we won't be for, I think, a very long time. But alectinib did much better than chemotherapy. we need to follow this longer to see if it means people are living longer. And in this study, people receive alectinib for 2 years. We don't know if that's enough. We don't know if that's too much. We don't know if we can further personalize that. But this is something that is approved by the FDA, April of 2024. This was approved, and I think is standard of care, which also means that we have to extend testing for ALK to anyone with surgery as well. And so the field is moving very quickly. It is really raising the bar for targeted therapy. We made a lot of progress in, I think, a relatively short period of time, but I also can see that we're going to make even more in the next couple of years. And so I think I'll stop the slides here and turn things back over to Ken and Summer for discussion.
Stephen, thank you. That's most impressive. So good evening, ALK community. Ken Culver here. I wanted to say that I've known Stephen since new professor at Georgetown University. It's nice to see, Stephen, how your career has prospered and how much great work you've done. Congratulations on that. Go back to one of the Crown study Kaplan-Meier curves. Stephen, would you mind re-showing that?
Sure, yeah, absolutely.
Like one of the things, hopefully one of the key take-home messages for everybody on the phone is that Crown isn't as simple as the curves. The curves are really fantastic, but then you have to decide about side effects. And one of the key things I want to ask Stephen, there we go, thank you. A couple things. So Stephen, if you look at this curve, by 36 months, 35% have already progressed. So there's a pool of patients, despite how great the data is, where the median progression-free survival is no different than being on alectinib, right? Because that's about. So I'm just wondering, is there any insight into who those patients might be versus those that are out at 80 months?
Yeah, this is a great question, and you're right. Up front, we still lose a lot of people. We focus on medians, we focus on long-term survivors. But this is a great reminder that we can't forget the people that sort of don't make it up into that 2 or 3 year mark. And there are patients that are in that group. I think that the ALK biology is different and they don't all behave the same. Some of them are not going to be as dependent on ALK and not as responsive to these targeted agents. We are working on ways to identify who those patients are. And do those patients need a different strategy, one where we combine it with chemotherapy, with an ADC, with a different type of treatment, because those are largely going to be ALK independent mechanisms of resistance, and some cases of even primary resistance. So it seems to be outside of ALK. Not all ALK fusions are the same, not all cancers are the same. And you're right, we do have an unfair amount of attrition in those first couple of years. I think alectinib and lorlatinib, generally, neither of them are going to save that population. So we need to do a better job, I think you and I, finding who those patients are and how we can rescue them, how we can keep them on that curve. What we also know, though, is that sometimes progression doesn't mean that the drug has sort of outlived its usefulness. And progression is a period where the cancer grows more than 20% from its baseline total volume, or we see a new spot. But there are cases where we might see one spot of progression and do something like radiation, do something like surgery. And then in the real world, after that radiation, that stereotactic radiation or surgery to remove that one area of growing, we may stay on the drug for many years after that. Now, the progression point will still happen at the very first moment we see that cancer grow. But in many cases, patients can remain on that drug for many years later. So progression doesn't always tell the whole story.
Thank you, Stephen. The next question is relates to this. So if you look at this curve and you say, my gosh, if I start on lorlatinib in the first line, I've got a pretty good shot at still being progression-free at 5 years. I got a really good shot at that, right? But if you first start an alectinib and then you go on lorlatinib second, now you've got about a 5.5 month survival. So I'm wondering, do you think there's something happening in the biology that the longer you're on alectinib, the less likely you are to respond to lorlatinib? Because a lot of our patients are saying, wow, should I be switching from alectinib? But apparently changing later doesn't have the same benefit as starting on lorlatinib. Is that how you see it?
Well, I think that the 5.5 months, I think, is not real. All right. And I think that that's a very different type of population. And we look at the brigatinib second line data, patients that qualified for that study and then did have second-line lorlatinib, there was closer to 2 years. And there the math does make a little bit more sense. I do believe that, my own practice going from alectinib to lorlatinib, seems like it's much more effective than that 5.5 months. But, should we switch treatment is always a tricky one because if we have a drug that we're tolerating well, that's working, it's always a gamble to make any kind of a switch. I think early progression is going to be different from later progression. And, someone's doing well on lorlatinib, we'll watch pretty closely, but I haven't been recommending patients switch. I do think that lorlatinib is going to be effective as a second-line agent. I think that 5.5 will be longer in the real world. And I do think that if we can better understand resistance and really focus on predicting who develops what kind of resistance, we can deliver better drugs. So it's tricky. In addition, the side effects are very different. And, there's always this unpredictable moment when we start a drug is we don't know how well the drug is going to be tolerated. When we make that switch, if someone has sort of more severe side effects, we don't have a great way to detect that. So if someone's tolerating alectinib well, it's working really well. I continue watching very closely, but I've been hesitant to make any changes.
That's a great point. Ken, anything else? Or was he frozen? He might be.
Dr. Liu,
Everyone-
could you stop your screen sharing?
Colin, do you want to jump in? And we have a bunch of other questions, by the way, too, which we'll all be getting to.
Hi, thanks very much for a great presentation. Really excellent. Some really interesting information that you presented about real life or real world durability of lorlatinib after alectinib or brigatinib, especially the brigatinib one that you mentioned. You mentioned about variant 3 and P53, and again, just showing that we're all different. I've actually been on alectinib now for 8 years, and I am both P53 and variant 3.
So it goes to show, not everyone. Right?
So it goes to show exactly.
Exactly right.
I ran a poll in the support group that's still ongoing, and it asked patients, how did they feel when they went from alectinib to lorlatinib? Which one did they prefer? And that poll's now been running for about 3 or 4 years. And the entire time, the trend's been very consistent that in the patient's mind, by a ratio of around about 2 to 1, they actually prefer how they feel on lorlatinib. And this was an absolute shock to us when we first ran the poll, because we were getting all these reports about how they felt on lorlatinib with all the neurological impacts and effects and weight gain and edema and all those sorts of things. But what hasn't really been acknowledged all that much, I guess, or it's starting to more now, is the amount of fatigue and muscle soreness that a lot of patients experience with alectinib and the energy levels. And so it's been very consistent over those 3 or 4 years that by a ratio of around about 2 to 1, patients prefer how they feel. Now, how do the people around them feel? That might be a different question. And then the last thing I wanted to ask about was, I'm very concerned. I know all the experts like you and Dr. Lin and Camage and all the people that really know ALK. I don't think any of them are routinely starting patients on 100 milligram lorlatinib. But I would at the same time guess that an extremely high percentage of general oncologists with little expertise in ALK are just going to their NCCN guidelines and saying, well, here it is, 100 milligrams, I'm going to start the patient on 100 milligrams. And then you're putting patients through all sorts of what I think are adverse effects that they don't need to go through. And what can we do to get people starting, and would you agree with starting people on 75 or even 50 milligrams, and then when they've shown, reasonable tolerability, doesn't have to be fantastic tolerability, but reasonable tolerability, then increase the dose rather than starting high and you'll end up at the same final dose. In fact, I think very often you might actually end up at a higher dose because people learn how to manage adverse effects if you don't get hit by them all at once at the very beginning.
Yeah. So, Colin, these are very sophisticated questions. I too am surprised at the poll results. I would say that I believe that when alectinib was approved in 2017, our understanding of the right doses to use for targeted therapy were a little different. And with chemotherapy, we know that the higher the dose is, the more effective it is. And so I feel like in the real world, dose reductions with alectinib back in 2017-18 were pretty low. And I think that people were staying on too high of a dose, probably for too long. The myalgias are something that are underreported, and many people didn't really attribute it to alectinib. And so we know now that it is a side effect that I think often occurs a little later, and is, I think, a much more serious one than people give credit for. And I do think that if dose reductions are done in response to that, can be managed pretty well. So hopefully with more appropriate dose reductions, the tolerability will reflect, I think, what expectations are for alectinib. For the dose of lorlatinib, this is a tricky one. When we look at models, the amount of alectinib you need to sort of kill the expected amount of cancer cells with ALK fusions is probably closer to 75 milligrams than 100 milligrams. And so you're right that 100 milligrams is probably more than what most patients need for ALK. When we use lorlatinib for ROS1, which is not part of its label, but is often used, there you probably do need the 100 milligrams. And so there, it's a little bit different chemistry between ALK and ROS1 for lorlatinib. Should we start everyone on 75? 100 milligrams is the approved dose. More recently, the FDA has really come down with a priority of ensuring people are not on too high of a dose. We call that Project Optimus, really the FDA's effort to optimize the dosing and to be sure that a lower dose won't give the same effect with less side effects. And I'll bet if you did a study of 75 versus 100, I don't think they would be very different in terms of efficacy. And I think 75 would be better tolerated. Now, that said, if we look at the numbers that are out there, only 23% of patients reduce the dose with lorlatinib. And so some people, clearly in the study, the majority, are able to stay on 100 milligrams. I wouldn't say it's wrong to start at 100 milligrams, wouldn't. But I do think if you're going to start at a high dose, you need to watch very closely at the first sign of side effects, you drop down. And I think there was a question in the chat, how low can you go? And certainly, 75, 50, 25. I have patients that are taking 25 a day and still have good disease control. It's really, we try to individualize the dose. And then there was another, I think, very savvy question. How do we find what that dose is? Is it based on weight or body mass index? We're not doing individual blood pharmacokinetic studies. Maybe we should, but we're not doing those. And I wish it was more scientific than trial and error, but it's not. We try a dose, and if someone has too many side effects, that tells us the dose is too high, and we have to drop that down. And so we don't have a good blood test for it. We don't use height or weight or race. It's not like chemotherapy. It really has to do with how your body breaks down the drug and excretes it. And for some people, they'll have the same effect at 25 as someone across the street might have at 100. So it really is trying to individualize it and watching very closely. If we start at 100 milligrams, you got to watch very closely, and you have to know what you're watching for. This isn't a drug where we start the medicine and see in a month, or see in 3 months. We really need to watch very closely at the beginning to make sure this is the right dose. And if you're doing that, most patients will need to drop their dose a bit.
Dr. Liu, thank you so much for covering that. And Colin, thank you for your question. Colin was one of our early co-founders of ALK-positive Inc. and also inaugurated our medical board. So thank you so much, Colin, for all you've done and continue to do in our group here. There were lots of questions on doses, so thank you for covering them off. I think you covered off most of them, so that all sounds good. There's really another really interesting one where someone said in China, some lung cancer researchers and oncologists are saying that if ALK patients are stable for 3 years on a TKI, they can stop the TKI treatment. He's asking if you've seen any data corresponding to this. Are you aware of this, and what is your view?
No, it's not something I would recommend. I think that even in cases where we have a complete response, where we started treatment, we don't see any cancer. I think that over time we've come to appreciate the limitations of these targeted drugs, and we don't think that these are cures. We don't think they're curative just by the way that they work. And so even if we had a complete response with the drug, I would still continue it, and I wouldn't stop at 3 years. I think what supports that is if we look at the adjuvant studies, when we do stop treatment in EGFR, at least, we do see that we see recurrence once we stop drug. And in those cases, maybe we shouldn't have. So I think that in this setting, if we're using this in the stage 4 setting, I would be very hesitant to stop, and I would continue.
That sounds good. We were talking a lot about the weight gain in particular people are experiencing on lorlatinib, and someone was asking about diet. Is there any advice you tend to give patients on this?
It's not quite as simple as that. And this is not a setting where you try to lower your cholesterol by changing your lifestyle. This is really an effect of the drug. And it has an effect on appetite, it has an effect on metabolism. And that weight gain, I think the best way to manage it is really adjusting dose. We don't know the effect of certain weight loss drugs that are out there. Are those medicines that we should be using? Are they going to be effective in here? Do we need to continue those forever? Really, I think the better approach is a dose modification. If we see a lot of weight gain, we know that can improve by lowering the dose. And we also know that lowering the dose doesn't necessarily impact how well the drugs work. I would start with adjusting the dose. And that's one side effect, to be fully transparent, that I think a lot of oncologists won't really pay attention to, where if I'm looking in the mirror every day, I can see if I'm gaining weight. But if I'm seeing a patient a few times a year, I may not really notice. And that really is something that patients will have to bring up. You get weighed every visit, that's true, but sometimes those are the things that some doctors might gloss over. It might not be caught in the clinic. So if weight gain is being seen, that is something that the patient should be comfortable telling their doctor about. And it's not because you're exercising less or because you're not eating as healthy. It's a side effect of this medicine. And hopefully more oncologists will have an awareness of that and pay attention to the weight and ask about that.
I was just going to say thank you so much for saying that. Shout it louder for those in the back, because that is often something that people struggle with, getting that message across. So thank you so much. And we can educate to all of our ALK community. This will be on YouTube, and this is for education purposes for care partners, patients, and members of your care team. So feel free to share this if you feel like you're not being heard. Also, piggybacking on when you were talking about dose reduction, somebody also said, how about scans for the stable patient? How do you feel? Typically we're quarterly for abdominal and chest, and then twice a year if we haven't had brain mets, more frequently if you have had brain mets. Do you typically stretch those out with someone who's been stable for several years?
It's tricky, right? Because you're tempted to, because you feel like you're on that curve and you're going to stay on that. But you also, the whole point of scans is to find something early before it causes any problems. If this drug is going to stop working, if the cancer is going to figure out what we're doing, ideally I would want to know the day that happens. And it's a balance, because scans expose us to radiation, scans generate a lot of anxiety, and there are costs involved. So always a balance. And I've seen some extreme cases where people might go a year without a scan. I wouldn't feel comfortable doing that. And I think that I'm not doing any favors by letting that go. I would say that for CT scans every 3 to 4 months is something that I stick with. For MRIs of the brain, because of the high tropism there, because of the high risk, I think twice a year is appropriate. And if someone has a history of brain metastases, generally every time I do a CAT scan, I'm doing an MRI as well. And I know it's a lot, and I don't minimize the inconvenience and the cost, but they serve a purpose. And we want to catch things early if they occur. And if it doesn't happen, if we go 10 years with these scans, then yeah, maybe we did it too often. But I think that's that's an okay place to be.
For sure. And maybe in the future we'll have some ctDNA to help us predict, right? But we're not really there yet.
Not there yet. I think we'll get there, and sooner than people think. So those tools will be there. We're getting a little more sophisticated. CT scans are not nearly as sensitive as we see. And when we look at, again, EGFR is sort of blazing the way here, but in the EGFR, I think where we're going to find our tools is in people that have had surgery. And what we've seen in people that have had surgery for EGFR is that by using certain lab tests, certain blood tests that are really based on that person's cancer, that we can detect progression in the blood many months before we would see it on the CT scan. And that is really, I think, where the field is going. It'll be in ALK, I think, sooner than people might think. And when we have these personalized surveillance tools, I think that's really going to be the future.
Wonderful. Dr. Liu, we had another question here. Someone asking if brain mets were present at diagnosis. Does progression usually occur in the brain first? Is there any correlation?
Yeah, not necessarily. All right. And so it certainly can. We have to watch those areas. But what we saw with lorlatinib is progression in the brain was pretty uncommon. So it depends on the drug. It depends on whether they've been radiated or not. I generally try not to radiate, or at least try to delay radiation as long as I can. But we see progression, in sort of all areas. So we have to watch for all of them.
Thank you. On one of the slides you showed the real world second line use of lorlatinib after brigatinib. Is there any data on the G1202R mutation and duration of a second line response? Anything on that?
Also a very sophisticated question. That resistance mutation is one that really plagues some of these early inhibitors, but we don't know for that study. That study was very limited as to what they could collect on that study. So it was really just watching for times of progression. It's not a precise science. We don't know about the specific resistance mutations. No.
Wonderful. Great. There are some questions also that relate to re-challenging with a prior TKI, moving backwards. What are your thoughts on that?
Don't usually do it. The way we look at it is, if a cancer survives a drug like crizotinib, and then we move on to alectinib, and then the alectinib stops working, all of the cancer that's in the body has lived through crizotinib, has experienced it, has, one would presume, the tools to survive there. There are rare cases, one famously published by Alice Shaw, that showed specific resistance mutation that sort of opened the door for older drugs. But for the most part, we go forward. There are individual cases where it makes sense, and each case is a little different. But for the most part, we generally wouldn't go if we stop the treatment for progression. Now, if someone had stopped the treatment for progression and took a long time off of a TKI, it's sort of a different story. And there's some interesting mathematical models being done at Moffitt in Tampa, Florida, looking at allowing sensitive clones to come back. But I think that if someone were taking an ALK inhibitor and it became time to move on to something like chemotherapy, and they were receiving chemotherapy for some time, and then the chemotherapy no longer was the right treatment, but they hadn't had any ALK inhibitor for a while, then very often going back to even that same ALK inhibitor can get a response. Now, it's not always going to be as durable as the first time, but we can get a second response. And so in that setting, re-challenge can work. But if someone's moving from alectinib to lorlatinib, can you go back from lorlatinib to alectinib? And in those cases, the answer is usually no.
Yeah, great.
So
One of our community
can I
members
jump in
wanted.
for a
Oh,
can I
sorry,
jump
of
in for a
course.
second, Yvonne? So, Stephen, in this case, a biopsy at the time of progression.
Mhm.
So how often are you able to do it? And if you can't, how do you make these tough decisions?
Yeah, so this is a very, again, a very sophisticated question, and it's almost a leading one. So on the podium and in public places, we'll say we always biopsy at progression. And you're looking for things like histologic transformation, moving from an adenocarcinoma to a squamous cancer to a small cell. And we know that can occur. We biopsy to see if there are specific mutational changes in the area that's growing specifically. How often do we actually do it? I would say less often than we say, and certainly not at 100%. While we say we always do it, I think we always want to do it. There was a study done in EGFR, a study just focused on biopsy. That was the whole study. People started on a TKI, at progression, they had a biopsy. And these were in academic sites where biopsy was paid for, and patients signed a consent, meaning they were fully on board with biopsy. and how frequently were they able to actually do the biopsy, and it was closer to 40% than 100%. So most of the time we can't. When we can, I think there's value in it. But if it's very dangerous to do that biopsy, if it's near a large blood vessel, if it's going to put someone at risk, then we typically would do a blood biopsy, a liquid biopsy, ctDNA. It's not a perfect test, and it won't tell us about histologic changes, but we can't expose people to too much risk with the biopsy. So how often do we do it? I'd say at least half the time in our clinic, but not always. And when we can't, we rely on liquid biopsy. There are some exciting research projects now looking at something called radiomics to try to predict histologic changes and even mutational changes, where can features on a CT scan or MRI through machine learning and artificial intelligence, can we predict mechanisms of resistance based on those features? And it sounds a little Star Trek-y, but it's probably going to happen at some point. So our tools will get better, but right now, while we try to do biopsy, often we can't.
Yeah, I'm glad you mentioned the use of blood biopsies there where possible, because that is hopefully in some cases it would help generate some data. There was another follow-up question on a point you were making earlier on why you prefer to not radiate or to delay radiation. This individual was saying he thought that the type of local treatment was viewed as an effective way to extend the use of drug or treat even progression. So maybe expand on that.
It is. So, I mean, stereotactic radiotherapy, SRS, stereotactic radiosurgery, focal high dose radiation to target areas of cancer in certain parts of the body, like the brain, can be very effective. Generally, if we're not radiating the whole brain, the toxicity is less. We don't see the memory loss, the personality changes that we might see with whole brain radiation. So it's very safe when we do it. Why don't I do it right away? It's a great question. And it's one that that is being studied sort of formally as well. Should we do it up front? The reason I try to avoid it, one, the drugs we use today, drugs like alectinib, brigatinib, and lorlatinib are very effective in the brain. And two, with radiation, one of the late side effects with radiation is something called radionecrosis, which is a late complication related to healing from these high doses of radiation. And we don't see it right away. You might see it years later, and it is related to the area that's radiated, the size of the tumor that's being radiated. Radionecrosis can be very debilitating. It can lead to headaches, increased pressure, nausea, vision changes, sometimes even seizures. It requires surgery, other treatment. It can be a serious complication, and we don't have great ways to treat that. So maybe scarred by challenging cases in my own clinic, I try to avoid putting us in that situation. If we need radiation, we need, I'm very comfortable with it, use a lot of it. But if I have a situation where I know a drug is going to work very well, and I think quicker than radiation will work, by the time radiation gets authorized, planned, and delivered, I feel like I could already get a response with giving alectinib or brigatinib or lorlatinib. So in these cases, I generally don't reach for radiation up front and watch closely. If we need radiation, don't hesitate. But all things equal, I would like to delay it primarily due to the risk of late side effects from radiation, for which we don't have great tools.
We want to be respectful of your time, so we'll wrap things up. I did just want to ask, people mentioned that they were struggling with swallowing TKIs. Someone else said, can you get an injection of a TKI? Is there a liquid version? Any insight into that? Or
I don't want to say anything wrong here. I don't know how well we can crush them or give them their formulations. Maybe Ken knows the answer to that. We can't inject them. That's not a way to do it yet. And I will also admit that, while I use a lot of alectinib, it is a lot of pills. It'll be 4 pills twice a day. Whereas brigatinib, lorlatinib at certain doses is only 1 pill a day. And so pill burden is something real as well. But a liquid form, I don't know. Ken, do you know offhand? Maybe not. So that's something that I would have to check with my pharmacist if we could crush them or give them in applesauce. It hasn't come up, but that is something I'd be happy to try to answer offline.
yes, we will dive deeper into that. Thank you so much. And then you mentioned blood biopsies.
Yep.
Ken, go ahead. See
I was going to
there?
say, I will ask all three of the companies that question.
Thanks,
Summer.
Okay, awesome. And then just blood biopsies, I was going to ask, this had been in the chat. Do you do them regularly prior to progression, or do you just, if you can't do tissue biopsy?
So at progression, I do them all the time. And so even if I am doing a tissue biopsy, I will also do a liquid biopsy. I think that they are complementary, that they complement each other. It would be nice if they were complementary, meaning no cost. I think the only barrier there is cost, but I think that most of the available companies now have done a very good job of making sure that cost isn't coming out of the patient's pocket, at least in the US. And so certainly if we could not do a tissue biopsy, we would absolutely do liquid biopsy. In many cases, we will do both.
Thank you. Colin, do you want to close it out for us? I see your hand raised back there.
I just in regards to the liquid forms of alectinib or lorlatinib, there was, and I can't remember whether it was alectinib or lorlatinib. I think it was lorlatinib with Pfizer, but I'm not 100% sure on that. But they did have a way of dispensing that in a liquid formulation for someone that had a real issue with taking pills. But pill burden's really, I monitor the patient feedback, and it's a very, very, very minor issue. It doesn't happen very much at all. So, yes, one's easier than 8, but the alectinib ones are actually pretty small, and it's not that hard to take them. I think most people don't have a problem with it. So anyway, thanks for a great presentation. Appreciate it.
Yes, it was so fabulous to have you here. We finally got to all meet you. So thank you for spending your Sunday evening with us. We're so very grateful.
Thanks for the invitation. I appreciate it. Appreciate all you do.
Yes,
Thank you,
thank you.
Dr.
And Mark will have some closing remarks for us.
I just want to let everyone know that ALKtALK and the Human Arts Program are really two separate issues, and we're fortunate to have these doctors come on a Sunday and give up their time and speak to us and educate us. But we also have our own classes, and Dana Credo heads those up. So Dana, can you give us a little idea of what's happening this month?
Yeah, this month we're taking I'm taking a break on a lot of our groups for the summer, because a lot of people are away, they're with family, so for those we're just taking a little bit of a break, but art therapy is continuing. I'm having a special event, Death Cafe, to educate us about hospice. Just, I feel like we all should be educated so we can make informed decisions.
And that'll be August, right? You're taking
That will be August 5th.
Yeah.
So that will not happen in July. Explore with the two groups, Explore with writing groups are continuing. Mindset Reset will continue. Book Club will continue. So we still have a lot to offer, and ALK Chat will also continue. So I'm hoping to see everybody in a square, and we're never feel alone. There's always somebody here to help support you.
Thank you so much, Dr. Liu, and we will see you guys coming up soon.
Take care, everybody. See you at Summit live or virtual. And be sure to attend our welcome reception Friday evening, again, live or virtual. More details to follow.
Thanks, Dr. Liu.
Dr. Liu.
Thank you.
Thank you.
Thank you.
Great job.
Thank you.
Thank you.
Thank you,
Thank
doctor.
you.
Amazing. Thank you,
Stephen.
doctor.
Thank you.
Thank you.